Okay, good morning. Good morning.
I have a question.
Yes.
How long does it take to get the background check back?
You won't get a background check back. They don't give you anything.
They don't.
You just go to the appointment and then they route it to the clearinghouse. That's why you need that ORI number,
Or I know.
but they don't.
So I'm going tomorrow.
Okay, they aren't going to give you anything. So after you do the background check, you can just register for the test.
Okay, that's what I'm gonna say. Thank you.
You're welcome. Okay, any other questions?
Oh, actually, I do have a question. So, I spoke to like one chair's office where they mentioned that they did it on a blue card or like a card. What does that mean?
Wait, cards won't work.
Right.
It has to be live scan digital,
Okay.
and it has to be photo enabled.
All right.
So I know Hernando County will do it for Hernando County residents.
Oh,
And I
yeah.
did call, and they did say that they do photo enabled, but only for Hernando County.
Yeah, I saw that.
All right, so let me turn my phone off real quick. All right, let me get your scores for chapter 7. Marwa,
90.
do you have 4 for me?
I don't.
That's fine.
Sorry.
Bobby,
90?
thank you. Do you have 4 for me?
Yes, that was 85.
Thank you. Kathy,
I got 100.
thank you. Taylor, Toya,
95.
thank you. Jade,
I don't know. I have to grade it.
that's fine. Dylan,
85.
thank you. Ezekiel,
85.
thank you. Veronica,
85.
thank you. Danielle, Antea, Katie, Stacy, Corey. Okay. All right, any questions on anything that you missed on chapter 7? Anything you need me to explain to you? You got it wrong. Do you know why you got it wrong and why the right answer is the right answer? So we had the game show yesterday, and we focused on basic nursing care provided by the nurse aide. And a lot of people kind of skip over this category because it deals with, when people think of nursing care, they think of bathing, dressing, grooming, all of the skills. But on the test, it's actually the biggest category of questions on the test. 24% of your test is going to come from this category. And it's all dealing with emergencies. Now, if you didn't have a chance to attend, you probably want to go back and watch the replay so you can get those 15 questions and kind of see the types of questions that are going to be on the exam, how they're going to be worded, and kind of give you an idea of how to process the answer. But that's probably the most important section of the written exam. And the reason is this. It all has to do with our scope of practice. We follow the care plan, we do normal, we follow the principles that tell us how to do the skills. We remember it's always about the patient, and we report everything to the RN. That's our scope of practice. The problem here is that I have trained you to go get the nurse for everything. And in an emergency situation, you can't leave your patient to go get the nurse. So you have to know what to do in emergencies. Does that make sense? So we will get the nurse. We'll probably send a staff member to go get the nurse, or we'll stabilize the patient or whatever. But we have to act in an emergency. If we don't, the patient isn't going to get the care that they need.
Okay, so you said don't go get the nurse if it's an emergency. Can you also use the call light to ask for help?
That's a great question. And the answer is yes, you can use the call light. The problem is, do you know who's responsible for answering the call lights?
You are.
Yeah. So if you hit the call light, it's basically summoning you, and you're already there. nurses don't generally answer the call lights. 90% of the time, call lights are, I have to go to the bathroom, I'd like a cup of water, or I'm cold. Those are all tasks you can complete. Does that make sense? Now that I've given you that answer, in acute care settings, hospitals, short-term rehabs, their call light system is set up a little different than other places. In those places, if you pull the call light out of the wall, where it's hooked up in the wall, when you pull that call light out, it automatically triggers a code blue. So pulling that call light out of the wall will get you the help that you need very quickly.
I didn't know that.
And they'll go over that in orientation wherever you go to work. That's something they cover in orientation. All right, so does that help answer your questions on that? Okay, so this is our last review. This is it. I will not review with you next week. So this is the last review. Last time I'm going to go through everything that we've learned. So if you don't have it by now, you're going to want to get the flashcards or make your own flashcards or do what you need to do. But you should be able, when I pull these up on the screen, you should be able to go through each one of those and fill in the blanks by this point. If you can't, you're not ready to test. Good?
Yes.
So this is a good way for you to find out, did I learn what I needed to learn? So, CNAs perform skill as directed on the, we follow the care plan, the whole care plan, and we observe for any, observations, changes, abnormalities, pain, anything that makes you go, if it registers with you, if something looks, sounds, feels, smells, whatever, a little off, you have to report it. You do not get to decide whether it's important enough to report. Okay? Who do we report those observations to?
The nurse.
The nurse. Every skill starts with an opening. Every opening starts with a
Knock.
Who are we greeting?
Position.
How are we addressing them?
Your name.
Who? What do we have to tell them about us? Okay, so name and title, name and position, and then what we're there to do. So we're going to describe that skill. Why do we have to describe the skill? What do we need from them?
It's comforting to them.
Consent.
We need
Consent.
consent.
Sorry.
Yes, yeah, we need consent, permission. And yes, it is comforting to them, but we need that consent. Once we get consent, we can close the, and then once we've touched that curtain, we're going to,
Wash your hands.
okay, and then we can go get our clean
Supplies.
supplies. When we're talking about supplies, we have to figure out whether we need gloves. How do I know if I need gloves? What are my 3 rules?
Personal skin.
Okay, so body fluids, personal skin, and non-intact skin. Very good. If we're going to be touching any of those 3, we need gloves. If the answer is no to all 3, you're just going to wash your hands before and wash your hands after. And that takes care of any pathogens that you might encounter. If we do decide to wear gloves, what's the first thing those gloves should touch? The patient. So when you were practicing, you kind of had a problem with that on Monday, didn't you? You kind of struggled with that a little. Because our first impulse, and this is why you guys need to practice, right? Because watching me do it is one thing, but actually getting in there and doing it yourself, you'll start to realize that, which step comes first? It really kind of makes you think about your steps. And a lot of times when we have gloves, we want to put them on as we're getting all of our supplies ready. So if I put those gloves on and then put the blanket on and pull the sheet down and get my water and all of that with those gloves on, are those gloves clean on the patient? I've touched mostly clean things, but it's still an unnecessary risk. So we're going to get all of our prep work done, all of it done, and then we put on our gloves.
But what if there's a transmission-based protocol where you have to put on the gown, the mask, and the gloves?
Okay, so in your book, if you go to, let me find it here. I know it's in there. All right, hold on. Let me get a book. Can I borrow your book? Hold on, I'll tell you what page. $124. You go to 124 and 125. So what we talked about so far is something called standard precautions. So they apply to everybody, every situation, all the time. We never change. It's always the same. And it's because we don't know if the patient has something communicable. But when we find out they do, then we have to institute something called transmission-based precautions. We used to call these isolation precautions. Now they're transmission-based initiatives or precautions, okay? And the steps that we're going to have to take, the methods we're going to have to use is going to be tied directly to how that pathogen spreads. So do you guys remember?
Yes.
We talked about the chain of infection. We have a pathogen, they have a host, they have to have a doorway out, and then they have to have a way of moving around. And we talked about most pathogens have to float or flow. So if the pathogen that we're working with is something like hepatitis or HIV that spread through body fluids, well, then we would want to protect, our clothing, our hands, anything that might touch something in the patient's environment. If the pathogen is airborne, then we have to cover up the holes on our face as well.
Like COVID.
So yeah, COVID was actually droplet, but yes, we want to, same thing, we want to cover those holes on our face. So the type of precautions that we're going to use are going to be based directly on the type of pathogen that we're encountering. Does that make sense? So there's a certain order we have to put all of that PPE, personal protective equipment, on, and there's an order that we have to take it off. And that just helps minimize cross-contamination. That's what you're going to see in the book on page 124 and 125. It shows you the donning and doffing order. So when we are working with just general patients, the first thing our gloves should touch is the patient. But if we're taking a step further and using transmission-based precautions, that additional gown, gloves, mask, eyewear, all of that is going to be put on before we even get into the room. Because with contact precautions, we don't want to touch anything with our bare hands or our uniform. Good? Does that make sense? Okay. So what we're talking about here is for standard precautions. Transmission-based precautions are going to be a step further, and it will start earlier before we even go in to see the patient. Good? All right, so once we've worn our gloves, we have to be careful not to cross-contaminate in our environment, so we have to be aware of what we're touching with those dirty gloves. And then we have to remove them correctly. We're going to pinch up and remove our hand, and then go under and remove the second glove. That way skin doesn't touch glove. If we're going to need supplies, we have to have a place to put them. So a barrier provides a clean area to put our clean supplies. We only touch supplies with clean hands, and those supplies cannot touch our uniform. We want to go get that barrier first before we get our supplies, so we're not tempted to hold supplies up against our uniform. Privacy blanket. These are used to keep our patient warm and protect their privacy. We're going to use them anytime the patient is uncovered or undressed. We put the privacy blanket on top of the sheet. We don't snap it or shake it, and then we pull the sheet down underneath. And then at the end of the skill, we remove the privacy blanket after we take our gloves off. Okay? Are you guys keeping up with it? Can you fill in those blanks pretty well?
Yes.
Remember that those review sheets, the review sheets that you had at the end of every class have all of these on it. All of these on it. So you've got this in your review packets. Linens must not touch your uniform. You have to have clean hands to get your linens. We don't snap or shake. Those 3 are repeats. We've seen those before, nothing new. Clean rolls toward me, dirty rolls away. That's how we minimize cross-contamination when we have linens that touch. We don't let clean or dirty linens touch the floor. Nothing goes on the floor, ever. Nothing goes on the floor. It doesn't matter whether it's clean or dirty. And unused items must be discarded. You're not going to have side rails in all settings. Our responsibility is to keep the patient safely in the center of the bed at all times. So if we're going to turn them on their side, in order for them to be in the center of the bed after the turn, we're going to scoot them toward us first and then roll them away. So scoot toward me and roll away. So after the turn, after the roll, they're in the middle of the bed. You always turn a patient facing away from you. You remain behind, the patient's behind. And our cardinal rule here is the patient must always be in the center of the bed. So even if you go through the steps of this, right? You scoot somebody towards you, you roll them on their side. The evaluator doesn't care about the steps. Yes, you did them, that's great. But the evaluator is going to look to see where the patient is after you've done those steps. If that patient is still too close to the edge of the bed, you're going to get penalized for that because it's unsafe. It's not just doing the steps. They have to mean something. Does that make sense? Has anybody ever told you they're sorry for something and you knew they didn't mean it?
Yeah.
And that sorry really meant absolutely nothing, right? It's just they said it, but it doesn't really mean anything. Same thing here. Okay, if you scoot somebody towards you and roll them and they're still too close to the edge of the bed,
You're not doing your job.
it doesn't mean anything. Okay, just because you did the steps doesn't mean that the patient is safe. Good? You guys understand that?
So if we were in that scenario during testing,
Mm-hmm.
are we still allowed to ask our patient to scoot in the middle?
Yeah.
So good question. So let's say I scoot somebody toward me a little bit, turn them on their side, see that they're close to the edge of the bed. What I would do is have them roll back onto the back, scoot closer to me, and let's roll them again. If I'm going to do as often as I need to get them in the middle of the bed. If they can kind of move on their own, like sideline position, says that they can move on their own, they just can't turn. In that case, I would probably ask them, can you scoot your bottom toward the middle of the bed, please? Scoot your bottom back toward me.
Okay.
Okay. So it depends on the level of ability of your patient. I can't give you one scenario that's going to cover every single patient you will ever encounter ever, because that's not realistic. So it depends on the level of ability of your patient. If your patient can scoot, have them scoot towards you. If they can't scoot, put them back on their back, pull them closer to you, and then roll them on their side. What was your question?
I forgot.
All right, so patients must always be in the middle of the bed. We have a lot of washing rules that we're going to perform. And all washing skills are done the same way. Basins are no soap zones. We're going to use a paper towel to turn the faucet on. We use warm water only, not hot, not cold, just warm. And it's not enough for us to check it. Who else has to check it? The patient. We're going to use the leaves method for wet body openings. Whatever we wash, we rinse. Whatever we rinse, we dry. We'll change that water if it gets cold or soapy. Don't get your surface wet, like bed, table. You protect whatever surface you're working on. And warm the lotion before you put it on and wipe off the excess after you put the lotion on. All basins are cleaned the same way. And we do a lot of basin cleaning, but it's simply rinse, dry, store for the test. That's all we have to do. Rinse, dry, store. But once you've rinsed that basin, make sure you're holding it with a paper towel because your hands are still dirty, or your gloves. So make sure you're holding it with a paper towel after you rinse it. Shoe rules. If the patient's feet hit the floor, we have to talk about their shoes. Slipper socks are not enough. Remember, you cannot walk a patient without shoes. In a clinical setting, if the patient doesn't have shoes, let the nurse know. Nurses have resources to help solve that problem. If we're going to use a gait belt to assist our patient, we want to check it to make sure that it's snug enough using how many fingers? 4 fingers. Before we lift a patient up to stand, we have to make sure their feet are
Flat.
flat on the floor. And before we lift them, we're going to count to 3. That way they're a partner in this. And then after we lift them, using that proper body mechanics, right? 1 foot in front of their feet, 1 foot beside their chair. As we lift them, you want to make sure their hands are on your shoulders so you're moving them as a unit. And that way their shoulders don't trail back. That's that body mechanics thing. Once we get them standing, we want to ask, how are you feeling? Are you dizzy? Everything good? And then we're going to let them lead. We'll walk slightly behind and to one side, but we'll let them lead. When we return a patient to the chair, they have to feel the chair behind them before you help them sit. So you want to say, back up so that you feel the chair, or can you feel the chair behind your legs? Something like that before you help them sit. And then the closing. Lots of C's here. We want to make sure they're in a clean environment. The bed is in the lowest position. You want to ask about comfort, both physical and emotional, so you can offer a magazine or address their preferences. Adjust the head of the bed if required. Just make them comfortable. Always leave your patient looking better than you found them. It's a great principle. We'll give them their call light, open the privacy curtain, and go wash our hands. If documentation is required, you would document after you wash your hands. And then our most important step of the closing is to end the scale with clean hands, so you have to wash your hands one more time. So those are all the principles that we have learned in class. Is anybody lost on those? All right, so let's review each of the skills that we've learned. Like I said, this is the last review you're going to do. So keep that in mind. The beginning of class 6, you'll probably want to watch this 20 minutes before you go test. Okay, because I'm going over all of the reviewing everything that we've learned up to this point. So a pulse is a measurement of how many times the heart beat over 1 minute. We're always going to support the arm when we count the pulse. Don't leave it hanging out in midair. We're going to, normal values are 60 to 100, and we're going to use the fingertips, not the flat area of our fingers, at the bendy part of the wrist, right where the thumb joins the wrist, way up here at the top. Thumb goes on the back side. Don't use your thumb to take a pulse. 2 fingers way up here, fingertips, not flat. Put your thumb on the back. For the test, we're going to say start and stop. So the evaluators start and stop counting. In Florida, we have to count twice, once with each evaluator. And this is a documentation skill. Dressing a resident. The way that we remember this is USA first. Undress strong arm first. And then we dress the weak arm first. We want to ask what they want to wear, ask about their clothing preferences. If they describe something that doesn't go, you can suggest an alternative, but we still honor their wishes, whatever they want. We'll get the clothing before we undress the patient. That minimizes exposure. We lift from below with a flat palm supporting the joints. When we put the new garment on, you want to avoid hyperflexing or overextending the joints. Anybody ever dress a baby?
Yes.
You know how their fingers can get caught up in those
Yes.
cuffs and bend backwards? Yeah, adults can do that too. And adults aren't nearly as bendy. So it's gonna hurt a whole lot more with adults. So we wanna make sure that we don't overextend or force movement as we do this. Adjust the clothing, make sure the toe seams are where they're supposed to be, the pants are up over the backside, the buttons are all buttoned correctly, all of those things. Try to minimize exposure as much as possible. All dirty items go in the hamper, and we'll put the call light in the, which hand? Stronger hand. Good. Hand and nail care. This is super easy. We're washing one hand. We're going to support the wrist and arm at all times. We'll soak the hand in water. Whatever we wash, we rinse. Whatever we rinse, we dry. You'll make sure the hand is resting on a towel. Use the beveled edge of an orange stick to clean under each nail, wiping it off in between nails. And then we use an emery board to file toward the center. One direction only. And then we apply lotion last.
And wipe both ends.
Always wipe off the excess. Making an occupied bed. All we're doing here is changing the bottom sheet a half at a time. So we'll get the patient laying on their side in the middle of the bed. Clean rolls toward me, dirty rolls away. So we'll roll the dirty sheet up, tuck it, roll the clean sheet toward us, tuck it. Try to minimize wrinkles, because wrinkles can contribute to bed sores. Make hospital corners. They don't have to be pretty, but get the corners of the sheet off the floor. Remember, nothing touches the floor. Loosen the sheet over the toes. When you make hospital corners, it's going to pull that sheet pretty tight over the toes, and it can actually cause the feet to, kind of bend down. So you want to loosen that sheet over the toes to make sure they got some wiggle room there. And replace the pillowcase with the opening facing away from the door. Sideline position is all about proper positioning. So we're just going to scoot the patient toward us. Furthest arm goes up, closest arm crosses the chest, closest knee is bent, furthest knee is angled.
Sorry. So basically, when we're changing the pillowcase, it's okay to have the patient have their head on the bed.
Yeah, that's fine. You don't want to leave that head without a pillow for very long. So that wouldn't be the first. I wouldn't take the pillow away, change the sheets, and then put the pillow back. It's too long without the pillow. But a brief time is fine.
Okay.
Good question. After we get the patient positioned properly for the turn, so furthest arm up, closest arm cross, closest knee bent, furthest knee angled, you're just going to roll them on their side. Put a pillow behind their back in a roll, one between the legs. Make sure those legs aren't directly one on top of each other. One under the upper arm to get that arm in a neutral position, and adjust the pillow under the head so it's not under that bottom shoulder. Call light is going to go in the bottom hand so that cord doesn't go across the neck. Foot care. It's all about inspecting. We'll support the foot as we move it. We're going to rest it on a towel just like hand and nail care. Whatever we wash, we rinse. Whatever we rinse, we dry. You don't want to put lotion between the toes. It holds in moisture, makes it kind of squishy and icky. No lotion between the toes, but everywhere else we'll put lotion, wipe off the excess. Don't allow their bare feet to touch the floor. Make sure there's a barrier there, always. The whole reason we're there, though, is to look. So you have to say something. I'm looking at your foot. It can be that simple. I'm looking at your foot, looking at the skin. Replace the sock. Make sure the toe seam lines up again, and then put their shoe back on. Mouth care. Don't overcomplicate this, guys. It's mouth care. You guys all know how to brush teeth. This is not complicated. But the patient does need to be in a fully upright sitting position. We're going to put a towel over their chest just to help protect their clothing. We wet the toothbrush before we apply the toothpaste, and then we brush. Top, bottom, front, back, tongue, brush it all. Let them rinse as much as they need to, and leave their mouth clean and dry at the end of the scale.
So when we're moving the pillow down, we would use our washed hands.
Yeah, and that's fine, because patient cooties are their cooties,
And then we could glove up after that.
right,
After you put the pillow down.
after you put the pillow down,
Okay.
yeah. Because the first, yeah,
Gotcha.
we want the first thing, the glove, even though it's the patient, right? Our rule is first thing our glove should touch is the patient. I still don't, those gloves are gonna go in somebody's mouth,
Gotcha.
you know? I want them to be pretty clean. So good question. Any others on that? Okay. They're not grading you that harshly on infection control. I want you guys to know these things, these infection control principles, because I'm gonna be the body in the bed one day. But the test, it's minimum skills competency. So as long as you're wearing gloves while you're in their mouth, that's all the test cares about. They don't care about, whether you touch the bed with clean hands or dirty hands, or touch the pillow with clean hands. They don't care. They don't care. They're not grading it. I care. I want to keep you and your patients safe. So I'm teaching you a little bit above what the test requires. Okay, good. If you remember on day one, I told you that you guys are focused on the test. I'm focused on the day after the test when you go to work. So that's why I'm giving you just a little bit extra understanding of infection control. All right, so the big thing here is we want to leave the patient's mouth and face clean and dry. Oh, good morning, everyone. Good morning. All right, respirations. You don't want to tell the patient that we're counting their respirations because it alters their breathing. Remember that in and out count as one. So it doesn't matter whether you count on the inhale or the exhale, doesn't matter, it's all one. Respirations, like pulse, always reported over 1 minute, but will count as long as the care plan tells us to. Normal is between 12 and 20. Again, we're going to say start and stop, so the evaluators start and stop when we do. And that alcohol patchwork I showed you, you can use on the test. Makes it easier.
What alcohol pad?
So when you're counting respirations, I put an alcohol pad on the
Okay.
tummy so that you can see the respirations easier.
I remember.
You can use that on the test. And this is a documentation skill. Range of motion, we've learned 2 range of motion so far. We learned shoulder and we learned hip, knee, and ankle. We have another range of motion we're going to learn, which is elbow and wrist, but it's all done the same way. When we're working with the patient doing range of motion, we lift extremities from below with a flat palm, 2 points of support near the joints, move slowly and smoothly, return all the way to the start position. Flexion extension is up, down. Abduction, adduction is side to side. And rotation is around. So the easy way to remember this, guys, is USA. There's that USA again. Up, down, side, side, around. All right. Denture care, just like mouth care with an extra step. But this comes in 2 parts. We're going to clean the dentures, and then we're going to clean the mouth the dentures came out of. So we actually need 2 sets of gloves for this. One for the dentures and one for mouth care. When we're cleaning the dentures, you want to put a washcloth in the sink. You want to use cool water. We'll store the clean dentures in a denture cup in clean water with a paper towel underneath as a coaster. And then we're just going to do mouth care. Make sure the patient's sitting fully upright. Put a towel over their chest. Wet your toothbrush. Put your toothpaste on. Brush all surfaces. Let them rinse. Leave their mouth clean and dry. All the same mouth care steps. Ambulate with a gait belt. Remember, our eyes should be on the patients at all times. That's where your focus needs to be here. We'll apply the gait belt while the patient is sitting. It goes on their waist over their clothing. We're going to help them to stand by holding the gait belt either on both sides or toward the back, depending on how big your patient is. We'll walk behind and to one side, letting the patient lead. Ask them how they feel as we're walking. We're going to help them sit and stand. So we're going to help them both times using that body mechanics. So 1 foot in front of their feet, 1 foot beside the chair. Grab the gait belt, help them stand. And then when we go to sit them down, we're going to do the same thing. 1 foot in front of the feet, 1 foot beside the chair. Grab the gait belt and help them sit. Don't pull that gait belt across their skin.
You're leaving?
We also learned partial bed bath. So partial bed bath can be abbreviated by just thinking about it face to waist, one arm and hand and back. Face first, no soap on the face. We're going to use the leaves method when we're cleaning the face because there's wet body openings there. So 1 leaf for one eye, 1 leaf for the other eye, 1 leaf for the face, and the last leaf for the nose. Yeah, boogers. We'll control that washcloth when cleaning, no floppy corners. Support extremities as you lift from below. Change that water if it gets cold or soapy. We're going to turn them on their side to wash, rinse, and dry the back. Give them a little back rub, wipe off the lotion, and make sure they're in a clean gown at the end of the skill. They don't care how you do it. Just make sure they're in a clean gown at the end of the skill. This patient doesn't have any weak body parts. They just can't bathe themselves. All right, so any questions on what we've gone over so far? They'll have some questions. All right, so today we have 3 skills that we're going to learn how to do. You will have some practice time at the end of class today. So if you go to page 72, we're going to start with wheelchair. So there is nothing new to learn. You now know all of the principles you need to know. There is nothing on that back wall we have not covered. Was it hard? Do you think that you'll be able to remember those items when you go to test?
Yeah.
All right. I actually have a shirt that I'm working on. It has really big letters, says CNA with an exclamation mark, but all of these are written in the CNA, the really big blocks. So, yeah. I'm wondering if the testing centers will notice. All right, so there's nothing new to learn here. We know all of our principles here. What we need to learn is skill specific. If you look down here, you can see test specific information. Somebody with your level of experience should be able to do this skill in 11 minutes or less. This is a live patient skill. So you guys could be a patient for this. That person is going to start out in bed. Documentation is not required. So if you go to page 73, let's look at the care plan. Care plan at the top of the page says, transfer the resident from bed into the wheelchair. The resident is unable to walk or take steps. Let's stop there for a second. I want you to underline that or highlight it. The patient is unable to walk or take steps. This is the part that fails most students on this particular skill. If we don't get the wheelchair close enough and that person playing the patient has to take a step to get into the wheelchair, our care plan says they can't do that. So that can really mess up your score. Okay, so I want to pay very close attention to that. That means that when we pull the wheelchair over to the bed to get the patient in it, it is going to be super close, almost touching. I basically will be able to get 1 sheet of paper between the patient and the wheelchair. It's got to be that close. And that's the biggest mistake most students make is they don't bring that wheelchair close enough. Says a gait belt or transfer belt is required to transfer the resident, and we already know how to use a gait belt. We learned that on Monday. So we put it around the waist, make sure it's not kinked or flipped over, make sure it's fastened appropriately, 4 fingers to make sure it's snug enough. We're going to use that same body mechanics, 1 foot in front of their feet, 1 foot beside them, and we'll lift them up, pivot them around, and sit them down in the wheelchair. So most of the skill you already know. What we have to focus on here is the wheelchair itself. It does say the resident will stay in the room. Let's talk about that for a second. If I've got a patient that from the bed and I put them in a wheelchair and I'm going to leave them in the room, do you think they want to stare at a wall?
No.
So what do you think a step is going to be here?
Take them for a walk.
It doesn't tell us. It says, what does our care plan say?
It says,
The last
required to
sentence.
transfer, okay, the resident will stay in the room.
Okay, so we can't take them for a walk.
Okay, so put on a TV.
Okay, but specifically, should you leave them facing the wall?
No, it's common sense. That's
So-
not what you would do.
We need to turn them around. Now, you would think that's common sense, but during the test,
Right.
you may forget that step if I don't bring it up. So we're going to make sure our patient is facing out at the end of the skill so that they have something to look at.
Gotcha.
Only one more out there, one way.
So good?
Yeah.
Well, we would only take them to the hallway if the care plan
Says so.
says so, but this care plan specifically tells us
Follow the care plan.
to leave them in the room.
I get it.
Yep. Okay. So shoe rules are going to govern this particular skill. Remember, if patient's feet hit the floor, we got to talk about the shoes. In this case, your patient is laying in bed, they do not have shoes on. So we need to get them sitting on the edge of the bed and then put shoes on them. Slipper socks are not enough. Remember that. We have to put the patient's shoes on prior to transferring. Some people will put the shoes on while they're in bed. I don't like that. I don't like shoes in the bed. So get them sitting on the side of the bed and then put their shoes on, just like you do at home. But remember, slipper socks are not enough. Once we get them sitting up, we'll put the gait belt on, check it with 4 fingers. We're going to verbally state that, or ask them, are your feet flat on the floor? We're going to count to 3. This is just like ambulate. And then once we have counted to 3 and we lift that patient up, we're going to swing them around and get them to sit in the wheelchair. But this is the problem. It says this patient can stand but cannot take steps. Okay? When I lift that patient up and swing them around, I don't want to be holding them in place while I ask them, hey, can you feel this chair behind you? It's a long time to be holding somebody. So what I'm going to do before I transfer them, before we stand up, I'm going to say, I'm going to pick you up and swing you around. When you feel that chair behind you, I want you to say, sit. So I prepare them, and then I get them to put their hands on my shoulders, grab the gait belt, and I'm going to say, remember, when you feel the chair, say sit. Ready? 1, 2, 3, up, over, sit, sit. I'm not holding them as long that way. Good? Good. Little preparation. All right. So remember, they have to be able to feel that chair behind them before we sit them down. This is the most important step here, is that they cannot walk or take steps. So we can't have the wheelchair positioned a far distance from them. If I lift this patient up, do you see how many steps they're going to have to take to get to that wheelchair? All right, so now let's learn a little bit about the wheelchair itself. Wheelchairs come in a couple of different varieties. You will be trained on the wheelchairs at your facility or with your patient if it's private. But this is a pretty standard wheelchair. This is the one you see in the picture here. Wheelchairs are usually kept folded for storage. To move a wheelchair that's folded, you kind of have to tip it up to get those small wheels off the floor. Otherwise, they get all bound up. To open a wheelchair, you simply hold the handles and pull it apart, just like that. To close a wheelchair, you lift up on the center of the seat, and it goes back together. No buttons to push, no levers to pull. It's simply made up, just like that. Not all wheelchairs open up all the way when you pull them apart. You may have to press down on the seat to get it to open up all the way. Brakes. Brakes, brakes, brakes when it comes to wheelchair. Brakes. Okay, so there's two different ways that brakes can be used. One, you push the lever forward to engage the brake. The other one, you pull the lever backwards to engage the brakes. I have one of each. There's nothing standard about this. You kind of have to figure out which way works. But to figure it out, if you look here, you can see a metal bar. I've got it highlighted in yellow for you. And you can see the edge of the tire. You can see there's a gap there. This metal bar is the brake. When you engage the brake, that metal bar bites into that tire, keeping it from moving. So if you're not sure how to engage the brakes on your wheelchair, you watch that bar. This is the bar right here. You watch that bar, and when it bites into the wheel, it's engaged. So here's the metal bar. When it bites into the wheel, it's engaged. To disengage the wheelchair, you would push the levers or pull them, whichever way, to get that bar off of the wheel. But this is the most important part of a wheelchair. Anytime that wheelchair is not actively in motion, it has to be locked. If it is not actively in motion, it has to be locked. Floors are rarely level. Concrete floors settle and crack, and that can cause dips. Wooden floors can swell with humidity, and that can cause them to dip. If we have an unlocked wheelchair with a patient in it and they are on an unlevel floor, they will start rolling. And the only thing that's going to stop them is whatever they run into, which could be a wall, could be another patient, could be a piece of equipment. Anytime the wheelchair is not actively in motion, it has to be locked. One of the largest lawsuits in Florida was regarding this specific situation. They had an immobile patient in a wheelchair. A dementia patient in a wheelchair. She was strapped in with a gait belt, and that's a no-no, by the way. They did not have an order for restraint. She was able to access a stairwell, and she went tumbling down concrete steps and died. So that wheelchair, if it had been locked, that patient would be just fine. Wheelchairs have to be locked. It's a safety issue. If the patient has safety awareness and is able to stop the wheelchair from rolling, they can unlock it and go anywhere they want to. But if they have no safety awareness or they're unable to stop the wheelchair on their own, it has to be locked. Okay? Good? Make sense? So wheelchair brakes are not a restraint, they're a safety measure. Remember that able-bodied wheelchairs, able-bodied patients, as long as they're able to stop the wheelchair, they can unlock it and go where they want to go. Our responsibility is to make sure it's locked. So it's all about safety. This is going to be on the written exam. And this will be on the written exam. So let's talk about the wheelchair height. And a lot of people don't really stop and think about this. You can see this pretty clear on this picture. It's this wheelchair and one of those chairs. You can see that there is a seat height difference. Do you see that that wheelchair is a little bit taller? The whole reason for that is because wheelchairs are designed to make the patient mobile. Right? We want to push the patient somewhere. So if we have a wheelchair and the patient's, the floor is much further away, that means the patient's legs are going to dangle. probably not be flat on the floor. And that's actually a danger for the patient. Let me show you what I mean. On the back of your legs, you've got veins and arteries. Arteries take blood down, veins bring blood back up. Veins are closer to the surface and they're a lower pressure system. Inside the veins are valves. So when your heart beats, the blood goes through the arteries down to your feet, and then that same heartbeat pushes blood from your feet back up to your heart, but it's slower. It doesn't work as effectively. So inside your veins, you've got these little compartments. So when your heart beats, the blood goes from one compartment to the next, and then the door's shut. And then the heart beats, and that blood goes one more up, and the door's shut. Everybody kind of get how that works from the legs? Okay. When we are sitting in a wheelchair and our legs are dangling, that means that the seat is going to press into that vein at the back of the knees. That's going to keep blood from going back to the heart effectively. Do you guys remember what I said about when blood slows down or stops? Anybody remember what happens?
Your blood pressure.
Okay,
Blood
so blood clots, yes. So it will affect the blood pressure, but we're really concerned about blood clots. So what happens when we have the patient's legs dangle? You're going to see swelling in those legs because that fluid can't return back to the heart. But we're also increasing the likelihood of blood clots forming because that blood, those veins are being squished and that blood can't get through that restriction, which can lead to blood clots. So for that reason, the patient's feet have to be supported on foot pedals. This is important. A lot of CNAs will put patients in the wheelchair, and if they can't find the foot pedals, they'll just leave the patient's legs dangling. That is not good for circulation, it's not good for blood pressure, and it's definitely not good for blood clots. So wheelchairs are going to have foot pedals. We have these right here are called leg rests, and then these black things are the foot pedals. So these leg rests are going to swing in and out, but at some point they're going to lock in place. So listen for the lock. You guys hear that lock? Hear that? Now that leg rest is securely in place. It's locked in. I can't put a patient into a wheelchair with these leg rests here though. Patient's going to get all tangled up and they're going to fall. We have to get these leg rests out of the way. So there's a catch right here at the back of the leg rest. I just move the catch forward and those leg rests swing out. This is the position the wheelchair needs to be in for transfers, in and out. Once the patient is in the wheelchair, we'll bring the leg rests forward. We'll push the foot pedals down and make sure their feet, are supported on those foot pedals. Good? Good. For storage, if I were to try to pull up on the center of the seat right now, watch what happens to those foot pedals. They push against each other. I'm not going to be able to get this wheelchair in that folded position. So wheelchairs that are folded for storage, the foot pedals are up, the leg rests are forward. So just like this. This is for storage. For transfers, the foot pedals are up and the leg rests are out. Good. I got a slide that's going to show you that. So two different parts here. We have foot pedals and we have leg rests. When in use, foot pedals are out, leg rests are forward. When stored, foot pedals are up, leg rests are forward. When we're transferring, foot pedals are up and leg rests are out.
Yes.
Good? You may have a test question that gives you graphics like this and asks you, what is the appropriate position for a wheelchair during transfers? You want to make sure that those leg rests are not in the way. So there was a lawsuit in Georgia about this. I feel really bad for this lady, the worker. This was a clerical worker. She thought she was doing the right thing. A woman and her daughter were in there. The woman was having some test done or whatever. Her daughter went to get the car, brought it up front. Transport wasn't there. So the receptionist or clerical worker said, no problem, the patient's in a wheelchair, I'll take you out to the car and get you loaded up. But she wasn't trained. So when she went to transfer the patient out of the wheelchair to help her into the car, she didn't move the leg rests and the foot pedals.
Oh, that ain't nice.
And the patient fell and ended up breaking her leg.
Oh my God.
And that resulted in a lawsuit. So even things that we think we should be able to do, if we haven't been trained, understand that what you know may not be the whole story. And we don't know what we don't know about skills. Does that make sense?
Yeah.
So if you haven't been trained to do a skill, don't do it. Because there's probably some little piece of information that you don't have that's going to affect the patient's safety. All right. So in order to transfer a patient out of the bed and into the wheelchair, we're going to bring the wheelchair near the bed. We're going to get the foot pedals and the leg rests out of the way. We'll pivot the patient around so they're sitting on the side of the bed and put their shoes on and their gait belt on. The order you do that doesn't matter. If you want to do shoes first, go ahead. If you want to do gait belt first, that's fine too. Does not matter.
Just put that gate belt on.
You want to get that wheelchair then moved closer. So it's going to be within reach when you're pivoting the patient, but not in your way. Once you get the patient sitting on the side of the bed ready for transfer, you'll bring that wheelchair close. And when I say close, I mean close. You're going to lock it. We're going to get the patient's, use the right body mechanics and get the patient prepared for the transfer. Tell them what's going to happen. And then you're going to stand them, turn them. When they feel that wheelchair, we'll sit them down. Put their feet on the foot pedals, lock the wheelchair, make sure it's facing away from the wall, and check their body position. That's it. So this is going to take you through the steps of this. So once the wheelchair is prepared, we'll pivot the patient, and you can actually pivot somebody your body size or even a little bigger. I'll show you how to do that. Once they're sitting on the side of the bed, we'll put their shoes on. We're going to get the wheelchair super close. I mean, almost touching that patient. Make sure that wheelchair is locked. We're going to make sure the gait belt is on with 4 fingers. Again, the order doesn't matter here. Gait belt first, shoes first. We'll move the wheelchair first, doesn't matter. We're going to use our proper body mechanics. And on the count of 3, we're going to lift them with our legs, not our back. Spin them around so they can feel that wheelchair. And then once they can feel it behind them, you're going to sit them down in the wheelchair, put their feet on the foot pedals, remove that gait belt, lock those wheels, make sure that they're facing away from the wall, and then do our closing. Questions? All right, I am going to show you the video for this. There's one thing about this video, though, because I'm getting ready to retape. Once you guys are graduated, I'm going to be retaping the videos. There's one thing about this video. You'll see me pick him up. When I pick him up and spin him around, I don't ask him if he can feel that wheelchair behind him. Remember, that is a required step. So they've added it recently. So we're going to make sure that we pause and they can feel that wheelchair behind them and then sit them down. Okay. When you pivot a patient onto the side of the bed, you're going to put your arm underneath their shoulders and over their knees. Most people try to put a hand under their knees. This doesn't work. This is like the honeymoon carry. That's not going to work. What you want is this. If you have your hands in this position, it's just a simple pivot. Super easy.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good. How are you?
Wonderful. I need to get you up and into a wheelchair. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get your supplies, and I'll be right back.
Okay.
Okay, Mr. Jones, I'm going to pivot you around so you're sitting on the edge of the bed. I'll need you to scoot toward me first, if you would, please. Okay. And I'm going to ask you to cross your arms over your chest. I'm going to put one arm behind your shoulders. Maintain a wide stance and put the other arm over your knee. And on the count of 3, I'm going to pivot you. Ready? 1, 2, 3. Are you comfortable?
Yes.
Okay, can you sit up straight for me, please?
Yes.
Are you dizzy at all?
No.
Okay. I'm going to assist you in putting your shoes on. Are your feet securely in your shoes?
Yes.
And are your feet flat on the floor?
Yes.
Okay, let me get a gait belt. I'm going to place this gait belt around your waist, and this is going to help me lift you and pivot you into the wheelchair, okay?
Okay.
I'm going to place this around your waist. Go ahead and raise your arms, and then you can relax. We'll make sure that there's 4 fingers between the gait belt and the patient, and then lock it into place in the second guard. Let me get the wheelchair. I'm going to position the wheelchair next to the bed so it's at a slight angle, almost touching the patient. And we'll lock it into place. Okay, Mr. Jones, can you bring your feet together? And slightly back, thank you. I'm going to ask you to put your hands on my shoulders. On the count of 3, I'm going to lift you, pivot, and sit you down in the wheelchair, okay?
Okay.
Go ahead and put your hands up here. And on the count of 3, 1, 2, 3. Thank you very much. Are you comfortable?
Yes.
Okay, I'm going to remove the gait belt. Can you lift your arm, please? Thank you. Okay, I'm going to unlock the wheelchair and swing you around. Okay, Mr. Jones, I'm going to lock your wheelchair in place. And then I'll position the leg rests and foot pedals to support your legs. I'm going to lift your foot. I'm going to lift your foot. There you go. Okay, Mr. Jones, here's your call light. If you should need anything at all, please let me know. Are you comfortable?
Yes.
Can I get you any reading material?
No, thank you.
Okay, I'm going to open your privacy curtain and wash my hands. Thank you.
Thank you.
After washing my hands, I'll think about all the steps of my skill, make any corrections, and tell the evaluator my skill is done. All right, any questions on wheelchair? Any questions? All right, we're going to move on to feeding a resident in a chair. So go to page 108 in your book.
Since Williams chair is completely different. They take the foot pedals completely off and then they'll put it back on. What I've seen even like the director of the facility do it. They'll pull up the wheelchair right next to the bed. They'll hook their foot in the wheel so it doesn't move even after you break it because you can still move it by accident. And then once they have the resident that they're going to transfer, they kind of do the same thing but without the gait belt. But they put one leg between theirs. Is that okay?
Okay.
I was curious because I'm like, this kind of like,
See it done.
yeah.
Yes, so I'm going to address all of that, but one by one, okay? So you are going to find wherever you go to work that there's going to be differences in the way the skills are done. Doesn't matter whether it's the hospital, an assisted living, a nursing home, home care, whatever. You're going to find that there are different ways to do the skills. I am showing you one way that is specific to the state exam. That doesn't mean it's the only way, okay? But I'm gonna have a seat because we're gonna have a conversation about this.
Okay.
So there's two issues here that I want to discuss. Have you guys ever played telephone?
Yes.
You know, where I tell you something and then you tell her and it goes all the way around the room. What happens when it gets over to you?
It's all jumbled and not the correct thing.
Yeah, it's not exactly the same, right? Okay. When you go to work, wherever it is that you go to work, you are going to have an orientation period where you're going to be assigned to another CNA or another worker, and they're going to kind of show you the ropes, right? So they got their information from somebody else, and they got their information from somebody else, and they got their information from somebody else. So understand that what you have seen may or may not be the way it's supposed to be done, because, you know, employees train other employees. So how do we know how things are supposed to be done then? Well, every facility has a book called a policy and procedure manual. How many of you guys work now anywhere? Work anywhere. Okay. Every employment has a policy and procedure manual. Doesn't matter whether it's fast food or a restaurant or a daycare center, there's always a policy and procedure manual. So let me explain to you what this policy and procedure manual is. A couple of years ago, I hired a house cleaner because I'm busy. I was writing a book. I was actually writing 2 books at the time, editing videos, doing my class. I was just busy. So I hired a house cleaner. I never had a house cleaner before in my life. Didn't know what to expect. But these people came recommended, so I hired them. And I didn't give them any guidelines. I was just like, hey, clean my house. Thinking they would know what to do. They're house cleaners. But they didn't move any of my little throw rugs in my bathroom when they mopped. They didn't, when they cleaned the sliding glass doors, they didn't go all the way to the top. It was just what they could reach. When they cleaned my counters off, they didn't move my toaster or my can opener or anything like that, right? So even though they cleaned my house, they really didn't clean my house the way I wanted it cleaned.
It's called surface cleaning.
Does that make sense?
That's what it's called.
And it's because I didn't establish clear guidelines, what I wanted done. Now, if I'd had a conversation with them in the beginning and said, hey, this is what I want done, then we would all be on the same page, right? So that's what your policy and procedure manual is. It's your employer telling you, specifically you, hey, this is how we want stuff done. So when you're asking me this question, okay, my first question is, what does the policy and procedure manual tell you to do?
I honestly don't remember. I was 18 at the time, freshly in the healthcare system, so I was like still learning.
Right, and that's kind of the problem here is that most of us don't even know where the policy and procedure manual is. We've never really looked anything up. We just go by what the people that we're working with told us to do. But is it possible that that's not accurate?
Sure.
Okay. So we have to kind of understand this. So I know it's a long answer, right? But when you have questions about, hey, is this the right way to do this? Remember, there's more than one way to do anything. More than one way to do anything. But is this the right way to do this here? And the answer is going to be, look at your policy and procedure manual. This is way more important than employees give it credit for, though, because if the facility gets sued, let's say that you transfer a patient using the process you were shown, right? You put your foot in the wheelchair, the wheel, you put your leg in between the patient, and when you go to move them, to transfer them, their leg gets tangled up in yours and both of you fall. Very possible.
Yeah.
Very possible.
So the patient's gonna sue the facility for medical expenses, and so are you, right? Because you broke your leg, you can't work. Work comp's gonna take care of some of it, but you're probably gonna sue them. So what's gonna happen is that when that lawsuit comes about, the lawyers are going to pull that policy procedure manual. And they're gonna look at what you did and what the policy procedure manual told you to do. And if they are not the same, that facility will win. 100% of the time. Because the policy procedure manual is their contract with you. They're only gonna cover you if you follow those instructions.
And that's what,
Kind of like the care plan.
Yep.
Does that make sense?
yes, it is.
And the problem is that most of us have never ever looked at a policy procedure manual. Don't even know where, it's up on a shelf somewhere collecting dust, probably don't even know where to find it in your facility. There is one,
And you can ask for one.
you can ask for one,
By law, they have to let you have it.
but it's surprising how many employees don't understand that that is the one thing that covers you. And you've got to make sure you're doing the skills the way they want them done. Now, this is even more important when we talk about getting a new job. So let's say that you've worked in a hospital for 12 years as a CNA. You know what you're doing. You run circles around everybody. You've been precepting other CNAs. You've got it all down. And you leave that position and go to a different hospital. And they show you what to do there. You still have an orientation period. They show you how things are done there. You're probably going to say something along the lines of, well, that's not how I did it in my last place. And that statement holds no water because you're not at your last place. We have to do things the way this employer wants them done. Remember, there's lots of different ways to do the skills. Does that kind of help?
Yes, it does a lot.
So I'm not telling you, all of that to say, I'm not telling you that what they're showing you is right or wrong. I can't pass judgment in any way because I don't know what your policy and procedure says. Now, interestingly enough, locally, most of our facilities, the policy and procedure manuals, what they use to write them is the book you have in front of you.
Good.
Because this has been thoroughly researched and meets not just testing standards, but best nursing practices. So I'm not saying that they're showing you the wrong way, but I would definitely want to go back and look at the policy to make sure that you're covered. I personally don't like having one leg in between the patients because you're turning this patient, right? They're not taking steps in most cases, you're pivoting them. Well, that means that their legs are literally trying to pivot around an obstacle, you. And that can very easily lead to a tripping situation. So I personally don't like that process, but that doesn't make it wrong. Okay. Does that make sense?
Yeah.
Okay, I know, long answer, sorry.
No, actually, that answered everything, so I was like very thankful for it.
All right, so let's go to page 108. We're going to learn how to feed a patient, and then we'll go on break. You will have about an hour of practice today. All right, so here again, nothing new to learn. Nothing new to learn here. We know all of the principles involved in performing this skill, so let's, at the bottom, you'll see your test-specific information. Somebody with your level of experience should be able to do this in 9 minutes or less. You're going to see how ridiculous that is in just a minute. They give you way, way, way more time than you need for this skill. Way more time. But if you look at the second icon there, you'll see that a testing student may be your patient for this. So you may be a patient being fed during the test. Now, what they're going to be feeding you is a very small single-serve pudding or applesauce cup. When you are the patient for this skill, they're going to take you aside. The evaluators are going to take you aside and give you a script to follow. tell you exactly what to say and do. Make sure you pay attention to what they're telling you. You don't want to make this hard on somebody. You don't want to drool or pretend that you can't swallow properly. You're going to be you. Whoops. You are going to be you. So you're going to chew and swallow just like you chew and swallow. They are going to tell you to take 4 bites. After 4 bites, they're going to tell you to refuse any more food nicely. Just say, I'm done, I'm finished, whatever. No matter what the CNA says, tell them you're done. So for the test, you're only taking 4 bites of something, pudding or applesauce. If you don't happen to like pudding or applesauce, please try to choke down 4 bites.
Got it.
Okay? Don't make this difficult on the evaluators. Where do those evaluators want to be?
Anywhere but there.
Anywhere but there. Absolutely. So if you have feeding and she says she's allergic to pudding or to milk, and that's all I've got today is pudding, no applesauce, and you say that you've got a mouth, you had dental surgery or something, and you say that you're feeling very nauseous because you're all stressed out about testing, and and I get around the room, I'm just trying to find somebody for you to get partnered with. And that's going to put me in a really bad mood if I have to work that hard. Okay. So even if pudding or applesauce isn't your thing, try to choke down a couple bites. Now, if you are allergic, please let them know that. They do not want anybody going into anaphylactic shock during the test. Okay. So allergic's a little different. So the evaluators will give the patient for this skill some very specific instructions. So let's look at the care plan at the top of page 109. Our care plan tells us to feed a resident a snack who is unable to feed him or herself. The resident is sitting in a chair in an inappropriate position for eating. Underline that. I don't care what your eyes tell you. This patient is not in an appropriate eating position. No matter what your eyes tell you, our care plan is telling us they're not in an appropriate position. So what does that mean? Well, remember I said that your patient is going to get instructions, right? If you're the patient, you're going to get instructions. Well, one of the things that they're going to tell you to do is to slump or slouch. So I'm sitting in the chair. I'm the patient for this. Somebody's going to feed me. And I was told to slump or slouch before the skill even started. So this might be my idea of slumping or slouching. This probably isn't triggering any red flags that it's an inappropriate position for you.
It is for me.
It is, yeah, but some of you may kind of miss this. Even more difficult is this one. So if I'm the patient and I'm told to slump or slouch, every 12-year-old in the country eats dinner in this position. So this may not trigger anything in your mind thinking that this is inappropriate. Remember, appropriate means sitting upright. So it doesn't matter what your eyes are telling you for the test. Our care plan says that they're not in an appropriate position. So you have to address this. Now, for the test, all we have to do is ask them, can you sit up straight? You don't have to pull or push or reposition or anything like that. Just ask them, sit up straight, please. Good? Okay. All right, it also tells us to document the intake on a food and fluid intake form. You can see a sample there in the second column on page 109. You can also see a full page version of this on page 169. The problem with feeding, and this is why I used to teach this toward the beginning of the program. I've moved it to the end because it doesn't follow our normal rules.
It is so different than everything else that we've already done. So I really need you to kind of understand our rules so that we can now break them. That's why I kind of moved it to the end. Make sense? So we close the privacy curtain for every single skill we do except feeding. We don't close the privacy curtain for feeding. And that's because eating is a social event. People gather in groups to eat. Every major life milestone you've ever had has involved food. Birthday parties, graduations, weddings, funerals, baby showers, even backyard barbecues where you get together with other friends and family. Everything involves food. Eating is social. So when we close that curtain, we're binding that patient in, and it will actually affect their appetite. We saw this in real time with COVID. This was a huge revelation during COVID because during COVID, they restricted visitors in assisted livings and nursing homes. People could not go in and see their loved ones, but they also closed down the dining rooms, and they made all of these patients eat in their rooms. And collectively, the patients in nursing homes and assisted living facilities, the intake plummeted. And a lot of weight was lost by patients. Just removing that social aspect of eating affected their overall well-being. So this is pretty serious. We don't close the privacy curtain for this skill. Okay. It's also a skill where you have to have a conversation. Now, we've talked a little bit about what we should say to patients as we're doing the skills. And I usually talk out my skills, tell them what the steps are so that they understand what I'm doing with their body. This skill is different. We're not going to say, okay, I'm going to dip the spoon into the pudding and have it half full, and I'm going to bring it to your mouth, right? We're not telling them the steps like we do with other skills. We have to have an honest to God conversation with these people. It doesn't have to be a real one. You can make something up, but you have to have a conversation. So something like they're going to be playing a movie on the big screen in the theater later. I think it's Casablanca. Do you want to go? Or, hey, bingo this afternoon. The jackpot's up to $2.25, and Mildred thinks she's going to win it. What do you think? Or,
Ask
hey,
them about something that they like with her.
yeah,
They love that.
absolutely. Hey, did you see the Bucks game the other day? Right? Went into overtime, they held their own, and then they didn't do the 2 points at the end. So you can have conversations. It doesn't have to be real. You can make something up for the test. I don't care. They don't care. But you do have to have a conversation of some sort. Now, let's not talk about the test for a second. Let's talk about real life. When I am feeding a patient in real life, I look around their environment because I know I'm going to be there a little bit. So I look around their environment and I'm looking for conversation starters. People will display things that they are willing to talk about. We don't put our deepest, darkest family secrets up on our wall. So like in here, you can see a picture on my bookcase of me and my husband on a cruise. It was one of the first cruises that we took. I am absolutely willing to talk about my cruising. So, yeah, I did. So it's a picture. It's out in the public. I am willing to talk about it, and we could probably get through an entire meal, and I'll tell you everything you wanted to know about cruising and then some. I've been on 35 cruises.
Did you win?
So, no, I never went.
35.
35 cruises, yeah. We just took our 35th in August.
Wow.
Where did you go?
So, Cozumel. Yeah. I cruise out of Tampa mostly because it's cheap and I can get on a last minute special and 4 or 5 days, usually over the long weekend. It's a great way for me to unplug because I work a lot and my phone is always ringing. So it's a great way for me to force myself to unplug for a couple of days. And sometimes I need that. If it's a picture, it is
free to talk about. So I usually will look around a patient's environment, particularly a woman. If I have an older female resident, I look around and I'm looking for a specific picture. It's going to be a picture of a woman all made up. And these women put us to shame, ladies. And they do. They absolutely do. And then a man in uniform. And if I find that picture, I'll point to it and I'll say, oh my gosh, they are gorgeous. Were they movie stars? Did you know them? And watch her sit up a little straighter and go, oh no, honey, that was me. Now, what did I do? First, I made her feel good. That's going to increase her appetite, but it also gives me an opportunity for conversation. Oh, where was that taken? Tell me a little bit about, what was happening then. It gives me a lot of opportunities there for conversation. People are usually willing to talk about themselves. All they need is an opening. Okay? You can also look around the environment for other clues. I actually met a man who was knighted by the Queen of England. Now, that's pretty cool. Pretty cool. I met a man who was one of the engineers in the Apollo mission when we put a man on the moon.
Nice.
I've met some very, very interesting people that have led some amazing lives. And they want to talk about it. They want to tell you about it. All you have to do is give them an opening. Okay? Does that make sense? Okay. So look around their environment. And if not, if you don't have anything in the environment that you can use to jumpstart a conversation, I always have a couple of questions in my back pocket that I use for conversation starters. Long time ago, this is back, probably about 30 years ago. I was working in Citrus County, seeing patients in home care settings. And I went into a assisted living facility. I think it was Barrington Place. Could have been Brentwood, I'm not sure. And I was seeing this woman in her late 90s. I think she was like 96 or 94 or something, late 90s. And she had these horrible wounds on her legs that were going to take, 45 minutes to do wound care on. It was very extensive. So I pull up a chair. I'm going to be there a while. So I ask one of my normal conversation starters, what's the most exciting place you've ever been? I'm ready to go on a vacation. I'm not real sure where I want to go. So what's the most exciting place you've ever been? And she says, oh, honey, I've never been anywhere. Okay, this is Citrus County. You had to have gone somewhere. I mean, Florida, Walt Disney World. She says, no, I've never been out of the county. You've never left Citrus County? Really? Never? So she doesn't think she has anything to contribute to this conversation. I'm sitting up straight. I'm all in now because this is living history. This is something, you've never, ever, ever left Citrus County. You've never been to Ocala? She says, no. And then she thought, well, it's not entirely true. I was born in Brooksville, but I don't remember that.
Sad.
Wow. So let's talk about the changes you've seen in this county in 90-something years.
There you go. She's seen them too.
She remembers when the roads were paved. There were no paved roads in Citrus County when she was growing up. She remembers the first car dealership that went in. There were two families that fought, kind of like the Hatfields and McCoys. And the son from one family was supposed to marry the daughter from the other family, except she took off with some other guy. And that caused a huge scandal in the county. So we talked a little bit about that. But this is living history, guys. This isn't, dry, boring facts in a book. This woman lived her life in this county and never left. Wow. I made sure that she was on my schedule from that point forward. You never know what kind of lives your patients have led. But feeding a patient gives you the time to slow down and take the time to get to know them as a person. So for that reason, conversation is graded. You have to initiate some sort of a conversation so that you understand why that's important. Okay? Now, we're not talking with our mouths full, obviously, but we usually talk when we eat. You don't talk while you're eating. You're chewing, somebody else is talking. And then when they take a bite, you start talking. If you go into, let's say you go into Cody's, it's buy one, get one fajita day at Cody's. Awesome day to go. So you go into Cody's at lunchtime, and when you walk in there, there's 60 other people in there. Is it dead silent?
No.
How awkward would it be if it was dead silent? It'd be really awkward, right? We don't think about how much conversation is tied to our eating habits, but it is. Okay, good. All right. We don't use a barrier on the table. Our food tray is our barrier, so we don't have to get a barrier for this skill. And we have to sit. So that's one of the reasons I pulled the chair up. This is going to be the position that your patient is in when you feed them, but it's also going to be the position that you are in. It is the only skill that you are required to pull up a chair and have a seat. And that's because if you're standing over somebody, if I'm the one being fed,
It's intrusive.
and somebody is standing over me, it makes them feel rushed.
Yep.
It makes them feel like they're an inconvenience and they won't eat very well, but there's a power dynamic there as well. So we never want our patients to feel like they're beneath us. Good? Does that make sense? So you do have to sit for this particular skill. All right, so our skills-specific steps, we've already gone over most of these, but let's review them. We have to make sure the patient is sitting upright. We're going to offer a clothing protector and a hand wipe. They don't have to use them, but we are going to offer. Now, even though we're feeding the patient, it doesn't say that they're paralyzed and can't move. So if food starts to fall out of their mouth, they may pull their hand up there to wipe it away. Do you want dirty hands around a mouth when we're feeding the patient? Hand wipe. Cleans their hands. But it also helps with ritual. Most people wash their hands before they eat. If you don't, you should. We talked about that chain of infection thing, right? If you don't have it in your normal routine to wash your hands before you eat, you should, but your patient should as well, okay? We are going to offer a clothing protector. We do not call it a bib. It's not a bib. It is a clothing protector. Some people will want it. I wear everything I eat. Everything I eat, I need a clothing protector. My grandmother, if you offered her one, she would tell you in no uncertain terms, I am not a child. Do not treat me like one.
That's what you get most of the time.
Yep. So, and that's fine, but we do offer. Okay, so we're going to offer a clothing protector. We're going to sit and face the patient. We're going to have a conversation with them while we're feeding them. And we want to offer a drink before we feed them and every 2 or 3 bites. Now, here's where we're going to talk about preferences. Everybody eats a little differently. We don't pay attention to it. We don't really think about it, but everybody eats a little bit differently. Some people drink an entire cup of something before they eat. My aunt used to do that. She had been a model once upon a time, and she would drink an entire glass of water before she ever sat down to eat. She said it filled her up and kept her from overeating. It worked for her. She kept a thin figure. It doesn't work for me. I've tried. It just does not work. Some people don't drink until after a meal. Other people drink during a meal. Me, I don't have a lot of saliva, so I tend to drink as I eat to help things go down a little bit smoother. Everybody has different preferences, but it's beyond drinking. It's also eating. How many of you guys don't like your foods to touch? Okay. How many of you like your corn and mashed potatoes mixed? Okay. How many of you don't? Okay. How many of you eat your salad first? How many of you eat your salad with a meal? How many of you eat your salad after a meal? It's actually very European. Have the salad after the meal. Everybody has different preferences. Don't assume that the way you eat is the way the patient eats. Now, probably the strangest one I've ever seen, this is many, many years ago. I don't think we have too many of these people left, but back then we had a little old lady. I mean, she was little. She was tiny. She was maybe 80 pounds. She was a little thing. But she had been a Southern belle. I mean, a true Southern belle. And she would not eat anything in a sandwich form. Nothing. No hamburgers, no hot dogs. She wouldn't eat pizza. And I couldn't really get my head around what the holdup was
She
there.
didn't want to
So
eat with her hands.
I asked her family. It wasn't her hands.
Is she British? A lot of like European people, we have to eat with forks. Yeah.
She was actually a Southern belle.
No.
She had grown up on a plantation. And a lady did not take a bite out of food. So you could bring food to your mouth with a fork, that's fine, but you don't bite into a hot dog or a hamburger or pizza and that was one of their, just kind of their social constructs. I had never heard that. I wasn't familiar with it, but now that I knew what it was, we could alter her diet plan and make sure that, she was able to continue eating, even on days we served things you took a bite out of. So we would never really think about that, right? Because sandwiches are kind of part of our normal daily routines. We have bacon, egg, and cheese biscuits, and then we have Big Macs, and then we eat pizza. And, this is all stuff that's just kind of our normal diet, but understand that our normal diet may not be your patient's normal. So if you start to make observations like that, make sure you let the nurse know. Okay. Does that make sense?
Yes.
Okay. That was probably the most interesting one I've ever seen. All right, we're going to feed slowly. The spoon should only be half full. Remember, your patient's only going to take 4 bites. And the spoon is only half full. So, they're taking like 2 spoonfuls of the whole thing. So this is, and I told you they gave us 11 minutes to do this. It's a ridiculous amount of time. You don't need nearly that much time. All right, we're going to have a conversation. We've talked about that. And then when they say they're done, remember they're going to get instructions, take 4 bites, say they're done. When they say they're done, you have to offer 2 forms of encouragement. 2 forms. So I usually use 3. You can use any 2 out of this, but are you sure you don't want just 1 more bite? I always say that. And that's because they may be rushing because they think I have other things to do. So are you sure you don't want just 1 more bite for me? Come on, please, just 1 more. Again, you can get further with patients by being nice than being mean. The second thing that I'll say is, did you want something else from the kitchen? We've all had those days. We make something, we take a bite, and we're like, nope, not it. Not what I was looking for. We've all had that. And maybe your patient's having one of those days. So I'll ask, can I get you something else from the kitchen? And then the third thing I tell them is, if you get hungry later, we do have some snacks on the unit that we can get for you. So that they know that if they get hungry, something is there for them. Okay? You need to use at least 2 of those. We want to be as encouraging as possible. Now, I know I'm spending a lot of time on this. We are going to be feeding a lot of patients. Generally speaking, patients will remain at home even if they can't take care of other personal things. If they can't bathe themselves, they'll just stay at home. If they can't toilet themselves, they'll figure out how to use adult briefs and they'll stay at home. If they can't groom themselves, they'll just stop brushing their hair and they'll stay at home. If they can't dress themselves, they'll invest in some muumuus and sweatpants and they'll stay at home. The one thing that will drive them to a nursing home or assisted living facility is the inability to feed themselves. You are going to be feeding a lot of patients. And if we don't do this right, this will cause them to develop failure to thrive, and they will die. This is a huge blow. Let me explain to you the psychology behind this. Eating is the very first skill you become independent at. The very first one. You learn how to hold a bottle long before you're sitting, standing, crawling, or walking. You pick up peaches and Cheerios off a high chair tray and get them to your mouth long before you know what hungry is. We actually have to prop you up in a high chair because you can't even sit on your own yet, but you will still get food to your mouth. This is the first skill you become independent at. And when you are unable to feed yourself, it affects you psychologically in a way that no other skill can. You will be feeding a lot of patients. But the way that we feed them is going to affect how long they are on this planet. Does that make sense?
Yes.
I have seen a lot of CNAs that will put a tray in front of a patient, not feed them. They will see the food, they will smell the food, and then the CNA will take the tray away and mark that they refused because the CNA was lazy and didn't want to do it.
That's not good.
That's psychological torture as well as physical neglect.
She needs to be fired. Serious. Yeah, I wouldn't put up.
But it happens, and I need to make you guys aware of how that affects the patient. Make sense? Good. That's why I spend a lot of time on feeding, because it's important. All right. And like everything else, we're just going to leave the mouth and their face clean. So wipe them up. And then we will do the closing. This does require documentation. So we're going to spend a little bit of time talking about documentation for this particular skill. We're going to document on a food and fluid intake form, which looks like this. You'll see we have to check off whether it's a snack or a meal. Remember, it's a single serve pudding or applesauce. It's a snack. They're only taking 4 bites. The spoons are only half full, so about 25%. Now, liquid, how much they drink, that's up to the individual. They may not drink at all. They may drink the whole cup because they're getting ready to be tested and they're stressed, dry mouth. We don't know. Document how much they drank based on that. But eating, it'll only be 25%. So, details matter here. We're going to offer a hand wipe before we feed them. We're going to offer a clothing protector. We'll offer a drink before feeding and every 2 to 3 bites. We're going to let them lead. We're going to feed slow. Spoon should only be half full, and no childlike feeding techniques. So no planes, trains, or automobiles. No race cars. Nothing like that. When we document percentages, it's always based on a quarter scale. So if they eat everything on their plate, they ate 100%. If they eat nothing on their plate, they ate 0%. And then everything else is going to be estimated based on a quarter scale. So if they just picked at it, had a couple bites, 25%. They ate roughly half, 50%. If they ate most but not all, 75%. So in order to understand how this works, I've got an exercise for you. This is going to be on page, let's see here, hold on. We're going to talk about page 106. We're going to do this together, but let's take a look at this slide here. If this is what we started with, we had a sandwich, some broccoli, and some Jell-O. And you look at the first one there, how much of that did the patient eat, roughly?
25.
Yeah, they ate a couple bites, 25%. Yeah. What about this one?
Half.
Yeah, about 50%. What about that one? About 75, and what about that one?
85.
can give them credit for 100 for that. Doesn't have to be a true clean plate club. Close enough. Broccoli stalks, they really don't count. All right, now let's talk about fluid intake. Again, this is going to be on page 106 in your book. Fluid intake. We estimate food based on the quarter scale percentage, but we don't estimate liquid, we actually measure liquid. Now the problem is that everything in healthcare is documented in metric. And yet all of our measurements in America are usually done in ounces. So we have to be able to convert. 1 ounce is equal to 30 cc's. 1 ounce is equal to 30 cc's. So if we have 8 ounces of something, and we need to know how many cc's, we would multiply 8 by 30. Anybody know what that would be?
160. What, Bob? Really? 8
Yeah.
times 3 is 24, excuse me. Duh. Sorry.
That's
I don't know
okay.
what I was thinking. My mind is somewhere else right now. I'm sorry.
So 8 ounces would be how much?
I'm embarrassed. I
That's
really am.
fine. That's fine.
I know better.
204.
Okay. What about 6 ounces? 6 times 30 is 180. Yeah. So if you struggled with this, you probably want to kind of, because multiplication isn't something we use every day.
Yes, it is.
So you might want to just brush up on your 3 times table, and then we just add a 0 at the back. For the test, you will have a math question. You will. They'll either ask you to convert ounces to mLs. They'll say the patient had a 6-ounce cup of coffee. How many cc's or mLs does that equal? Or they will ask you to add up the total intake for a shift. In that case, you would add up all of the intake. So you will have a multiplication question or an addition question on the test, but you usually only get 1. Okay? So if you look on page 106, you can see that there are a couple activities there that help you determine how to estimate food and fluid intake. Over here on this side, we have the fluid intake. Now, the really cool thing about this is that prepackaged foods will have ounces on there, but it also will contain mLs. So on the front of your water bottle, Dylan, you should have ounces. Can you see how many ounces are in there?
16.9.
Okay, and then right next to it, it'll have your cc's or mLs.
500 milliliters.
500 milliliters. So when we have prepackaged foods, we can just read it right off the label. And you can see that here on page 106. You can see the milk actually has the mLs listed. Wherever you go to work, doesn't matter where, during orientation, they are going to show you the cups that they use. The coffee cup, the water cup, and usually, like their juice cups if they're not in prepackaged things. And they will tell you how many ounces each one of those things hold. So some coffee cups hold 8 ounces, some hold 10 ounces, some are really big and hold 12 ounces. They will tell you in their facility what those coffee cups hold. You want to pay attention to that, because if we have to document and take an output, we would want to know how many ounces that cup held. Okay? Good?
Yes.
Good. All right, let's go to page 132. And let me talk to you briefly about medical abbreviations. You will have a few medical abbreviations on the state exam. There aren't very many, but there will be a few. Anything that's highlighted in gray are ones that you probably need to know. But I want to go over these really briefly with you because they're not going to make sense if you try to make them make sense in English. They're not abbreviated English. They're abbreviated Latin. So in the first column there, you'll see the third one down says BID. Do you guys see that,
Yes.
BID? That's abbreviated Latin. B stands for bi. How many wheels does a bicycle have?
2.
Two. So B stands for bi, which means 2. So in this case, BID is 2 times in a day. TID would be
3.
T for try. Try is 3. And then Q, a little further down, you'll see QH, Q2H, Q3H, and so on. QH means every hour. Q stands for every. It actually stands for the Latin word for every. You'll also see QD, which is every day. QHS. HS is ora somni, or how they say bedtime in Latin. So QHS is every bedtime when they go to bed. Good?
Yes.
So if you,
remember these?
yeah,
Eventually, it's like locking them.
yeah, you will have 1 or 2 on the state exam. They're not very, very few. But the one that I really want you to know here is about 3/4 of the way down the first column, you'll see NPO. NPO means nothing by mouth. So this is important when we're talking about feeding patients. And again, it's abbreviated Latin. NPO is nothing by mouth. Don't try to make sense of it in English, it won't. It won't help you. You want to know CNA. You want to know RN. You want to know NPO. Those are the ones that you're most likely to see on the test. Okay? Good? There's a whole activity on page 133 to help you use these medical abbreviations in the way it would be used in a clinical setting, just to kind of get used to what they are and how they work. All right, so page 169 has that documentation form for you to play with if you want to. And page 107 tells you a little bit more about that intake and output that we were just talking about. Any questions?
No.
All right, so let me show you this video really quickly because I have nothing to teach you, and then we will go on break. The last skill that we're going to go over is Peri Care. Nothing really to teach you with Peri Care, other than we do have to talk a little bit about the infection control aspect, the infection risk with Peri Care. So we'll spend some time on that. Oh, handy. Okay, good morning. Thank you for your help. I watched your videos every day. I feel ready for the CNA test. I've applied for the class starting January 14th. Very good.
Hello?
Hi, Mr. Jones. My name is Patty. I'm your CNA today. Would you like a snack?
Yes, please.
Okay, I'm going to go wash my hands, get my supplies, and I'll be right back. Can I ask you to sit up straight for me, please?
Okay.
Thank you. Okay, Mr. Jones, let me get you a hand wipe so that you can wipe your hands. Would you like to take that? Thank you very much. Let me
Thank you.
dispose of this. Okay, can I offer you a clothing protector?
Yes, please.
I'll just place this on your chest. Okay, it looks like we have pudding. How does that sound?
Great.
Very good. Can I offer you a drink before we get started?
Please. Thank you.
You're welcome. Okay, are you ready?
Yes.
There you go. Do you have any plans for this afternoon?
No, I do not.
They're showing a movie on the big screen in the activity room. Would you like me to get more information on that for you?
Yes, please.
Okay. How does the pudding taste?
Delicious.
Very good. Ready for another?
Yes, please.
Okay. Can I offer you a drink? Would you like something to drink?
Yes, please.
All right. Ready for another bite?
Yes, please.
Ready for another bite?
I'm actually full.
Are you sure you wouldn't like just one more bite?
I'm okay, thank you.
Can I get you something else from the kitchen?
No, thank you.
Okay. Let me know if you get hungry later, and we'll get something to eat. We do have food available on the unit.
Thank you.
Going to take the napkin. There we go. I'll remove this clothing protector from you, and we're going to put this in dirty linen. I'm going to go take care of your tray. I'll be right back.
Okay, thank you.
Okay, I'm going to place the tray back on your table. Is there anything else I can get for you? A magazine, perhaps?
No, thank you.
Your call light is within reach. Please let me know if you should need anything. I'm going to go wash my hands and document.
Okay, thank you.
After washing my hands, I'm going to document the amount of food that this patient ate.
And the amount of fluid they drank.
Yeah.
And then we would wash our hands again.
Using my documentation form. I'll review the steps of my skill, make any corrections, and tell the evaluator my skill is done.
That did not take 11 minutes. You guys see that they give you a whole lot more time to do the skills than you actually need. So slow down, don't rush. You've got all the time you need. I put a sign up sheet for CPR. CPR is going to be Saturday from 9 a.m. until 1 p.m.
How much?
The cost is $45 for current students. If you're interested in coming, make sure you put your name and phone number there. And let's go ahead and go on break. Come back in 15 minutes.
That's fine. See you Saturday.
Okay, all right, no problem.
I can bring cash?
Yes, cash is
Just
good.
kidding, okay. Thank you.
Not right now. That'll be the only session. I probably will have one.
It's like 9 a.m., okay. Have a great day, man. Thank you.
One thing in the eight, yeah, one thing was like 70 cents or something.
It's 50 at corporate. I'm not corporate, I got a franchise.
It's here, right there.
It's terrible. Get what a personal for.
Just put it in there. It's really good. It's not that bad.
The CPR. I already got mine.
That's good.
Pulling out the word. I'm gonna be mad. What is it over there?
Give me a proof.
No. I'm sick on my myself.
So after every skill set that we do, we have to document it. I want to ask you that.
Only the ones that involve like fluid and food,
Okay, gotcha.
or any kind of skill that require like documentation like that, because it's important for the nurse to know how much nourishment the patient is getting.
And also, I wasn't sure when you take the pulse and everything, we have to document that too, right, on the test. Okay.
Like it depends on like what facility you like work in. So at this hospital, I'm sure like some of the nurses would have you get the patient's vitals for them. If you got multiple, then just get like a little book and then just write them down one by one.
Gotcha.
But just record all the vitals you see, all the vitals you get. Then say this is what I got. After it's still within range, I want to go check, but she'll know. Because they know they know to scrub off, they know to look at the numbers and tell right away. I worked for Trinity Rehab for 3 years in Trinity, and there, that's what we ended up doing. They had like 10 people to take care of, don't overlook the other shift. We took all the vitals first after we did the report. That's just pretty much where it depends on the setting.
Gotcha.
I'll probably follow everything as slow as you can, and then kind of learn where you can kind of be a little loose with it once you get in the field and get established.
Right.
I think it's best to do everything by the book first, and that way you can find out where you can kind of go a little bit loosey.
Yeah.
Depending on the facility.
Sure. You know what bitch was the medical observations, it's like the verbs, the ones that were she said that are in Latin.
The medical abbreviation?
Yeah, abbreviations.
Yeah, that's on page 133, 132 and 133.
There we go. Yeah, that's important. I had a question, and then my mother was testing me on it. She's like, "Oh, you got that wrong." But I was like, kind of makes sense to it, but she's like, in medical terms, it's not making sense. But she's like, just remember, if it's in medical terms, a whole different meaning to it. I was
Oh, yeah.
like, okay.
That's something I want to do too. Cause like there's abbreviations for words that can mean one thing in one field, but a whole total opposite in another field. You're like, wait, that's not what I remember about it.
Right.
I think the best bet is to get a medical abbreviations book and just go through them all like that. Depending on like which ones you think you'll be using more often. You know what? Actually, for the abbreviations, the best thing would probably be flashcards. Because you can put abbreviation on one side and definition on the other, and do it that way.
Yeah.
It really helped get it locked in.
Plug into your, yeah.
That's what I did the first time around, because there's so many out there.
Yeah. That's really been taken out with. I got that one.
Definitely takes a while.
It's, yeah, my mother speaks Latin, so it's kind of easy for me to comprehend
It's definitely a good thing.
it. Yeah.
You know, break it down for you. Okay. Yes, what that means. It's probably has some correlations too. after this, I'm heading towards either Perineal or Oakhill.
The Oakhill living
I don't know, I'm probably gonna apply for the hospitals.
hospitals.
Cause they can, I think you can learn more on the side of the hospital,
Yeah.
so then advance that way. Then when you wanna go for certification, that'd be easy because you already know everything.
Right. Yeah.
You don't have to go back to school for it, and just learn stuff on the side.
Because what I'm trying to do is trying to do this and then go to school for RN. Yeah.
And depending on the facility that you end up going into, I'm gonna go to work around your schooling.
Mhm.
But I doubt that stuff that's on too much.
Yeah.
So you're sending here, I haven't even came across you. Okay, so they're mixing together.
I wanted to know what's the math question that's going to be asking.
I don't know if it's the same specific question for everyone, or if they switch up depending on the test.
Yeah.
That way no one gets the same.
Answer the question.
So I'm surprised when she said that when you register, that's when the skills get picked. I didn't know that before.
Yeah. She's like, there's one math question. I'm just like, oh, whoa. Okay.
I think it's probably just how to convert. I'm going back over that.
What pretty much she was saying with the 1 ounces
Yeah.
into, just got to time to.
I convert that into an ounce. As long as you remember that multiplied by 3 when it comes time,
And
it's gonna be the best way to do it.
multiply it by 3, that's for everything. Okay. You pretty much just add a 0 to it.
Yeah.
Okay, got it.
Take the number in the ounces, multiply by 3, add a 0 in the ounce, which should be cc's. Convert to cc's.
And then what if they were asking for amounts? Same things, pretty much take the 3 times whatever the ounces.
I think if you did it that way, maybe you would divide it. I'm gonna ask her that
Yeah.
when she comes back, because you're breaking it down. And here
Yeah,
you're taking
that, I think that'd be an option too. 8 divided by 240, so it'd be like 3.
I can try and see if it would.
Yeah, yes,
I'm gonna say it, make sure it happens that way.
divided by 240.
Yeah.
Yeah, I got 30.
I took 180 divided by 3, and they gave me 6. But we're still at the 0 anyway, so.
Right.
And we just take away the 0 because you gotta think you're doing it backwards.
So 18 divided by 6. Yeah, 3.
Yeah.
Yeah. Okay. So now I know.
When you go from ounces to cc's, you're going from large to small. That's why you multiply. But if you're going the other way, you go, you would divide and take away the zero. And you would still get the same answer at the beginning.
Yeah, that gives me more time. So this weekend, if I ask my brother that he took this class, he passed, and he also had another video that like broke down. It's the same way she did it.
Yeah.
And I became his dummy when I was in his room. But I'm gonna do it on him, and he walked me through it.
That's the best idea. If you have any resources like that, utilize them as much as you can.
Yeah.
Because that'll really make the difference once you get in the field. You just feel like 1, 2, 3, like, okay, let's do this.
Yeah.
And it's like, okay.
Constant.
That's how it is. I mean, some of it's just practice and knowing everything.
Correct.
Yeah, like I said, so she put it towards us. As long as we focus on the patient and not subjecting them to any kind of harm, that's what it's based on.
Pretty much, yeah.
If you focus on that and just make sure everything's safe, you should be good to go.
Yeah.
Remind me after class. I gotta get some flashcards. Okay. Anybody have any questions on what we've learned so far? I just turned the air down or air off because I know it's cold in here. Anybody have any questions? No?
Okay.
All right. We're gonna move on. Oops. We're going to move on to Peri Care now. This is not a hard skill. You guys know most of what you need to know to do this skill. But what we do need to focus on is the infection control aspect of this. So we're going to review the urinary system, how it works, so that we can understand how what we do can affect it. So page 152 shows you all of the principles involved, and this is a long skill. We have a lot of principles here, everything but shoe rules. They're all spelled out for you here. Skill specific is here. Down at the bottom, you can see the test specific information. Somebody with your level of experience should be able to do this in 17 minutes or less. So it is a long skill. This is going to be done on a mannequin. Yay. Mannequin. They're going to be laying in bed. The evaluator will play the voice of the mannequin for you. You know all of the principles to do this. We learned the leaves method, which we're going to use for this skill. We learned that on Monday. So let's look at the care plan at the top of page 153. It says the female patient has been incontinent of urine and needs perineal care. The pad under the resident is wet, but the hospital gown and bedding is dry. So that's our instructions. Pretty easy. This patient is not wearing an adult brief. They're open to air. They're laying on a pad. We're going to talk about that a little bit in just a minute, why that would be. All right, so to understand how to do Peri Care, we kind of have to review our urinary system. So we have two kidneys. Most people have two kidneys. Those kidneys filter blood 24 hours a day. They never, ever stop. They filter the blood. They take out the bad stuff, the impurities, and they create urine. That urine drips down tubes and collects in a bladder. So drip, 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 24 hours a day. There is a valve at the bottom of your bladder that holds all of that urine in the bladder. When you go to the bathroom, that valve opens, your bladder empties, the valve closes again, and you're good to go for another couple of hours. That is a normally functioning urinary system. When a patient is incontinent, the only part of the system that's broken is the valve. Kidneys still filter blood 24 hours a day. Still creates urine 24 hours a day. That urine still drips down those same tubes into the bladder 24 hours a day. Drip, drip, drip. The problem is that that valve doesn't hold those drips in the bladder, so they come out. Your incontinent patient will be wet 24 hours a day. Drip, drip, drip. If you have a patient who is dry, 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 really, really wet, they are not incontinent. That valve is working to keep them dry. Your incontinent patients are going to be wet all the time. Do you guys understand the difference there? Okay. Incontinent patients are always going to be wet, but the problem is that adult urine isn't like baby urine. The acid in our urine is going to be based on, how
how do I put this? The acid levels of the foods we eat and the drinks we drink. Babies are on a very bland diet. They have breast milk, formula, rice cereal, very bland, not very acidic at all. So their urine, the acid in their urine is very, very mild. It doesn't really affect them too much. But adults, what we eat is a lot of acid, and that acid is going to be excreted in our urine. So what do you think would happen if you hold acid next to the skin for a long period of time? It's going to burn. So with a baby, we can put a diaper on a baby, put them in bed, let them sleep all night, wake them up, and they still have skin on their tushes. Right? You do that with an adult, that acid will eat the skin and we'll end up with wounds. So we have to understand that adult urine is not like baby urine. It is different. Any questions on that? Adult urine is not like baby urine? Any questions? So when we think about incontinence, we generally think about this. We don't call them diapers. They're called adult briefs, or depends. We don't call them diapers. But we generally think, well, if a patient's incontinent, they're going to be wearing an adult diaper all the time, or adult brief all the time. And that may not necessarily be true. Those adult briefs, when they're out of bed, will protect their dignity. It holds the urine. It's good when you're in a social setting. But that's going to hold the urine right up next to the skin. It also blocks out light and holds in body heat. So now we've got warm, dark, moist on the inside of this adult brief. That can contribute to infections. So while the patient's out of bed, this is a good idea, right? Protects dignity. But when the patient is in bed, there's a better way. When you have an incontinent patient in bed, if we don't put an adult brief on them, if we just leave them open to air on a pad, that pad is going to collect the urine, but it's going to pull it away from the skin. It also allows light and air to circulate, so you get rid of that infection risk, or at least minimize it, because it's not warm, dark, moist, held right up against the skin. Does that make sense? And not all your patients are going to be comfortable being open to air. That's something that the nurse will assess and put in the care plan. But this care plan has us changing a pad under a patient that is open to air. Any questions on this? This is much healthier for the patient. All right. Let's think about that incontinence pad for a second. As that urine comes out, remember, drip, drip, drip all the time, it's going to spread along that pad. Okay? It's going to meet air temperature. What do we know about room temperature? Room temperature always, anybody remember this?
73.
Yeah.
73.
Right, around 72, 73, that urine, when it comes out of the body, is about 101 degrees. Remember, our normal body temperature is like 98.6. Urine, because it's made in our furnace area, is a little warmer, so when it comes out, it's like 101 degrees. So that 101 degree urine hits the 72 degree air, and it's going to cool down because room temperature always wins. So now we've got cold urine on a pad. Do you think that's comfortable for your patients?
No.
No. If you were laying on that pad, what's the first thing you'd want done?
To get out of it or off of it.
Yeah, change that pad. So that's the first thing we're going to do here. We're going to change the pad out and get them on a dry pad. But now we got a wet butt on a dry pad. So when we're all done with this skill, when we clean the front of the patient and then we clean the back of the patient, we're going to change that pad out one more time so we have a clean butt on a clean pad. Good? Any questions? Washing rules are going to apply here. Remember, basins are no soap zones, so we don't add soap to the basin. We're going to use a paper towel to turn the faucet on. We're going to check the water. It should feel warm. Not hot, not cold, just warm. And we're going to ask our patient to check it. We're going to use that leaves method for the body openings. We're going to wash, rinse, and dry, and we don't want to get our surface wet. So our bed in this case, that's why we have a pad under them while we clean. So here's our rules. We don't add soap to the basin. We're going to use a paper towel to turn the water on. We're going to check the water with our wrist. It should feel warm. Have the patient check it. We'll change it if it gets cold or soapy. And we're going to use that leaves method that we learned before. We'll wash, rinse, and dry. And we're going to use one leaf for each stroke that we make. I'm going to get to that in just a second. Change that water if it gets cold or soapy. And no lotion for this particular skill. So if we look at the care plan one more time, it says the female patient has been incontinent of urine and needs Peri Care. The pad under the resident is wet, but the hospital gown and bedding is dry. I'm going to tell you that's a miracle. It never happens like that in a real life setting. You're going to be changing the gown, the pad, and probably the top sheet too. If it's wet, it needs to be changed. But the test is going to make this a little bit easier for us. Okay? Plus it's a mannequin skill. So to do this skill, we'll do our opening. Knock, knock, knock. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I need to do Peri Care. You can put this in any words you want. Your patient knows what Peri Care is. You are never the first person to do a skill. Who do you think the first person to do a skill on the patient would be? The nurse. If it's a brand new skill that needs to be done and the patient has never had that skill done before, that is not normal for the patient. What do CNAs do? Normal. So anything not normal would have to be done by the nurse. They know what, your patient knows what Peri Care is. So you can say Peri Care. That's fine. If you want to say, I'm going to do personal care, that's fine. I'm going to wash you down below. That's fine. But you want to keep this pretty professional.
Mm-hmm.
You don't want to say, I'm going to wash your hoo-ha. Okay? You want to keep this pretty professional. Try to not use slang terms. Older patients may not even know what a hoo-ha is. All right, so we'll get our barrier first, and then we'll go get all of our supplies. We're going to get some water and let the patient check it. We'll put a privacy blanket over the patient. We'll put our gloves on right before we perform the skill, and then we're going to change this chucks that's under the patient. You know how to do this. It's the exact same process as changing a sheet. Clean rolls toward me, dirty rolls away. Except this is a little smaller than the sheet, so it actually becomes a little easier. Nothing new here to learn. When we roll the blanket, the privacy blanket up to expose our patient, we only want to expose what we're working on. So let me show you something. This is going to make you guys really uncomfortable on purpose. All right, so I've got a patient here. I've done my whole opening. Knock, knock, knock. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to do Peri Care. Is that okay? Close curtain, wash hands. I've done all of that. I went and got all of my supplies. I'm ready to get started, right? So I've got this blanket that I have put on the patient. Remember, I only unfold. I don't snap or shake. I put the blanket on the patient. I pulled the sheet down to about their knees. Now this hand fell off. Girl, you're falling apart. Okay, so I have put the blanket on the patient. Have a hand. I pulled the sheet down. I've changed the pad out under the patient. And now I'm going to get ready to start cleaning. So I've got to expose her, right? There is a big difference between exposing her medically and just exposing her. Now let me show you what I mean. She's got pants on, so you're not going to get all that uncomfortable. But if I just pull her blanket up and her gown up to expose her private area like this, And she doesn't have pants on. She's all exposed. How comfortable do you think she is?
Very uncomfortable.
Very uncomfortable. So instead of doing that, what I would do, so I have my blanket here. I'm going to roll the gown up inside the blanket, just like this. And then I would lay a towel over her legs. And now the only area that's exposed is her private area. This is medical exposure. Do you guys understand the difference between the two? Don't just pull the blanket up and expose her. She'll probably resist. Now, when I'm all done with the skill, I can unroll that gown, unroll the blanket, and when I do, the gown spreads out. I don't have to touch it with my hands. My dirty gloves. You'll see what I mean as we go. All right, so when we're getting ready to do the skill, we'll roll that gown up in the blanket, and then we're going to put a towel over her legs so you can see that the area that's exposed is minimized. Very specific. We'll wring out our washcloths, no drippy wet washcloths. We're going to soak all 5 corners. Now, the way that we do this is we have our washcloth. Oops, sorry guys. We have our washcloth. We got it out of the basin. We wrung it out. We soaked all 5 corners. So soap, fold soap, fold soap, fold soap, fold soap. And now I'm going to clean. So I'm going to hold it in my hand. Leaves method. I'm going to hold her open a little bit. And I'm going to clean from top to bottom and move away. Right down the center and fold that open. Top to bottom down one side. Fold that over. Top to bottom down the other side, fold that over. Top to bottom down the skin fold. This is where the leg and the groin meet, that crease. We'll fold that over and top to bottom down that skin fold. So middle, side, side, skin fold, skin fold. You're moving from the middle out. Never move back up. Top to bottom, move away. Never move back up. They're looking for that. So we only move from top to bottom. Whatever we wash, we rinse. Same way. Get a rinse washcloth. Down the middle, fold the leaf. One side, fold the leaf. The other side, fold the leaf. Skin fold, fold the leaf, skin fold. And then whatever we rinse, we dry. Top to bottom, always moving away from the urethra. After we do that, we'll cover her back up with her blanket, and then we're going to scoot her toward us and roll her on her side. Remember that scoot and roll we learned? Once we roll her on her side, we're going to wash the back side. So I'll get my washcloth, wring it out real well, and I'm going to soak 4 corners. Soap, fold soap, fold soap, fold soap. And I'm going to start at the anal opening, go up the center crease. It's kind of like a riverbed. It's where all the urine's going to run. And then I'm going to wash one cheek, fold that over, wash the other cheek, fold that over, and once more up the center. We'll put that aside. Whatever we wash, we rinse. Exact same way. So use the leaf method. I'm going to rinse up the middle. One side, the other side, up the middle again, using a leaf for each stroke. We'll dry, bottom to top. We're going to change that pad out one more time. Clean rolls toward me, dirty rolls away. And then we'll get our patient covered and take care of all of our supplies. So dirty linens go in the hamper. My basin goes over and gets dumped, rinsed, and stored. We get our patient all set back up, and then we're going to remove our gloves and remove that privacy blanket and pull the sheet up. Then our closing. Pretty easy.
This is not a hard skill, but it is a long skill. However, you know all of the principles you need to do this skill. There's nothing you need to learn. Okay? You're just going to apply what you've already learned to this skill. You're going to have a hard time with this skill just because of where you're washing. Your patient probably is not nearly as embarrassed as you are. The more matter of fact you are, the more you'll put your patient at ease. If I go in and I go, yeah, I gotta clean. Yeah. My patient's gonna have zero confidence in me. If I go in and I say, all right, Miss Jones, we need to do Peri Care, and I just tell her every step that I'm doing, she will have a whole lot more confidence in me. So this is one that you probably want to practice on the mannequin just to develop that confidence level that you're going to need. So you men, I do want to talk to you for a second. Right or wrong, you have a higher than average chance of getting partial bed bath, Peri Care, or catheter care. And that's because they assume that you're probably not all that comfortable with it and probably haven't practiced it. So just a word of warning. All right, so let me show you this skill. And the rest of the class will be practice. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I need to do Peri Care. Is that okay? Okay, let me close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'm going to start out with a barrier. This gives me a clean place to place my clean supplies. So I'll place the barrier on the overbed table. And now I'll start gathering my supplies. I'm going to need 2 chucks, 4 washcloths, a privacy blanket, a towel. I'll place these items on the overbed table. I'll need a basin and soap. And I'm going to need a set of gloves. Okay, Miss Jones, let me go fill the basin. I'll use a paper towel to turn the water on. I'll make sure it's warm. Not hot, not cold, just warm. Miss Jones, would you like to check the water temperature and make sure it's okay? It's good? Good. I'll place my washcloths in the water. Okay, Miss Jones, I'm going to place this privacy blanket over you. This is going to help keep you warm and protect your privacy while we do this skill. I'm going to spread the blanket out, being careful not to shake it or snap it. And then I'm going to pull your sheet down to about your knees. Now I'll get my chucks ready for use. I'm going to unfold the chucks, hold it up lengthwise, and roll it toward me. And I'll repeat that with the second one. Clean rolls toward me, dirty rolls away. Now I'll get my gloves on. Okay, Miss Jones, in just a moment, I'm going to ask you to scoot toward me And we're gonna roll you onto your left side so I can change the chucks that's under you. I'll place one of the chucks on the bed. Miss Jones, can you scoot toward me, please? Thank you. And roll up on your left side. 1, 2, 3. I'm going to roll the dirty chucks toward the patient. Tuck it under her hip. Unroll the clean one and tuck it under the soiled. Miss Jones, can you roll back onto your back, please? Thank you. And scoot to the middle of the bed. Okay, I'll come around to the other side of the bed now. Miss Jones, can you scoot toward me, please? And roll up on your right side. 1, 2, 3. We'll remove the soiled chucks from the bed and unroll the clean one. This is going to be thrown away. Okay, Miss Jones, we're going to start cleaning now. I'm going to roll your blanket up to about your waist. This is going to expose you. Please let me know if you're uncomfortable in any way. So I'll roll the blanket up, and on the way I'm going to try to get that gown rolled inside the blanket so that exposes only the peri area. I'll cover her upper legs with a towel, and then get my first washcloth. I'm going to wring this out and soak 5 corners. 1, 2, 3, 4, 5. Okay, Miss Jones, I'm going to clean now. I'll use the heel of my hand at the top of her peri area and my index and middle finger to spread her slightly open so I can clean down the inside middle, top to bottom, and then we'll fold that leaf over. We're going to clean the outside labia, top to bottom, down one side, and fold that over. The third leaf will clean the other side of the labia, top to bottom, fold that leaf over. The fourth leaf is going to clean this area between the leg and the groin, this skin fold, top to bottom. We're going to fold that over, and we'll repeat it on this side, top to bottom. Now we'll place the washcloth back on the barrier. The second washcloth we're going to wring out, and we're going to rinse all of those areas the same way we washed. So we're going to hold her slightly open to clean down the middle, top to bottom. Fold that over. We're going to rinse down one side of the labia, top to bottom. Fold that over. Rinse the other side of the labia, top to bottom. Fold that over. We're going to rinse the skin fold down one side, top to bottom. Fold that over. And the other skin fold, top to bottom. We'll set that aside. Now we're going to dry all of those areas using short, soft strokes or a gentle pat. I'm going to unroll the blanket, which will place her gown back over her legs. Okay, Mrs. Jones, I'm going to scoot you toward me now, and we're going to roll you onto your left side so I can clean your back side. Go ahead and scoot toward me, and we're going to roll you over onto your left side. 1, 2, 3. The evaluator will hold the mannequin in place for you to complete your cleaning of the patient's backside. Okay, I'm going to take the fourth washcloth, wring it out really well, and we're going to soak 4 corners. 1, 2, 3, 4. I'm going to start at the anal opening and go up the center crease, right up the middle, and we'll fold that leaf over. The second leaf will clean one buttocks. We're going to fold that over. The third leaf will clean the other side of the buttocks. We'll fold that leaf over. And the fourth leaf will clean from the anal opening up the center crease one last time. We're going to set that aside. Whatever we wash, we rinse. So I'll wring that out. And I'm going to rinse the same way we washed. So from the anal opening up the center crease, fold that over. One buttocks, fold that over. The other side of the buttocks, fold that over. And once more up the center crease. And then we'll dry all of those areas. Okay, Miss Jones, I'm going to change that pad out from under you so you're on a nice clean pad. We'll roll the soiled chucks toward the patient and tuck it under her hip. Unroll the clean chucks and tuck it under the soiled. Miss Jones, come on back, please. And scoot to the middle. Thank you. Okay, Miss Jones, go ahead and scoot toward me. And roll up on your right side. 1, 2, 3. Thank you. We'll remove the soiled chucks from the bed and unroll the clean. Okay. Go ahead and scoot back to the middle, please. This is going to be thrown away. Okay, Ms. Jones, I need to put all of my soiled items away and clean my basin. I'll be back in just a moment to get you situated. These items will go in dirty linen. And the basin is going to be cleaned the same way we clean everything else. We'll dump the water into the sink, rinse the basin, pick it up with a paper towel and dry the inside. We'll discard that paper towel. We'll dry the outside and discard that paper towel. And then we'll get the soap. I'll use the paper towel to open the drawer and store the basin back inside. These paper towels will now be thrown away. The barrier is going to be disposed of. And now I can remove my gloves. Okay, Ms. Jones, I'm now going to gather the privacy blanket up and pull your sheet back up. So I'll collect the privacy blanket by lifting from the bottom or underside of the blanket. I'm going to pull the sheet up and ball the blanket up into a ball. That way no trailing edges will contaminate other surfaces. Okay, Ms. Jones, let me go put this in dirty linen. Are you comfortable? Is there anything else I can get for you while I'm here, like a magazine? Okay, here's your call light. If you should need anything at all, please let me know. I'm going to go open your curtain and wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections, and then let the evaluator know my skill is done. All right, any questions on that? No? Okay. So if you look at the syllabus, I don't know if you have looked at the syllabus, we only have 3 skills left to go. We have assist with bedpan, catheter care, and emptying the drainage bag. These are all toileting skills. We'll go over them on Monday. You should have about an hour and a half of practice time on Monday as well. So if you remember me saying the first 2 weeks, I talk nonstop. And then as we get through some of the skills, you get more and more practice time. So next week, you'll have probably about an hour and a half of practice time. You also have this room available on Wednesdays and Thursdays from 1 o'clock for you guys, you know, from the end of class up until 4. When you come into practice on Thursdays, I may or may not be here. Okay, just kind of depends. But if the room is locked, just go let Jake know and he'll open it. You guys can come in and practice. You have access to the videos on our website you can watch. You have your skills book that tells you step by step how to do the skills. Please make sure you're in uniform when you're practicing. CPR will be on Saturday at 9 a.m. So just come on Saturday. If you cash is preferred, if you're paying by card, I'll take your payment on the day of. Okay. If you want to sign up for CPR, the sign up sheet is there.
Do we get certified at the end of it?
You do. Yep. So homework, you're going to have 2 chapters because it is a weekend. You'll have chapter 8, which is on nutrition, and you'll have chapter 9, which is on rehabilitation. Chapter 8 is a little more complex. It's a short chapter, but it's the concepts, if you're not familiar with nutrition, may be a little challenging for you. So spend a little bit of time on chapter 8. All right, any questions, final questions before we go on? On page 154, we talked about female Peri Care, but page 154 gives you the process for male Peri Care. In male Peri Care, you simply start at the top, move your way down the shaft, clean the scrotum, rinse, dry. It's pretty easy, pretty self-explanatory. Everything's out there. Infection risk is much lower in men. But we always move away from the urethra. All right, if there's no other questions, we're going to go ahead and sign off of online. Thank you guys so much for joining us. We look forward to seeing you for our next live session on Monday. Wednesday is graduation, and I'll be going over a lot of very useful information for you on graduation day as well about keeping your certification, finding a job, and how to ace that interview, especially with that. Tell me a little bit about yourself. How do you answer that question? So we'll go over that in class on Wednesday. So thank you guys for joining us. Have a fantastic weekend. Until next time, happy caregiving. Bye.